Okay, so let's dive into the next part of this lecture. Okay, so I'm actually going to open up with a slide again from Dr. Amanda Fu-Nguyen from UWA, and she was very grateful, I'm very grateful that she allowed me to share her slide. It was just ironic that it was last week, or 2 weeks ago, she held a free webinar on Bruxism as well, and I recommend you're watching it as well because I learned a lot of information. And she shared this flowchart on treating adult bruxism, which pretty much matches everything I do in clinic and correlates with everything I taught in the previous lecture. So I'll run through this briefly, but if you watch Amanda's lecture, it goes through a lot more detail. But whenever you see a patient who clenches or grinds their teeth, what you'll look at for the signs and symptoms, and we're pretty much already aware of the signs and symptoms of clenching and grinding. It will be teeth wear, hypertrophy, jaw pain, scalloping tongue, etc. And then when we see the signs or symptoms, next thing we have to then think is bruxism is not the complete diagnosis. So as I said before, earlier, it's a sign or symptom of potentially an underlying disorder. So we have to think, is it really bruxism? Is it awake or sleep bruxism? And is it related with any other disorders such as epilepsy, OSA, REM behavior disorders, GERD, etc.? We have to consider that the definition of bruxism and classified. So it could be not a risk, it could be a protective behavior, or it could be a risk factor where it's actually causing problems. And then we have to see, is it awake or sleep bruxism, and then is it primary or secondary? So if it's secondary, it's normally related with some other condition or medications. If it's primary, it's normally no known cause we can find. And there's these different medical history things that we could see in our patients. So when I'm looking at sleep, any of my patients, I'm already doing my treatment planning from the minute I read their medical history. If I see that they've put high blood pressure, diabetes, reflux, I'm already thinking they probably have OSA. If they they smoke, they have alcohol, they're on different medications such as antidepressants, etc. I'm really thinking, okay, they could be having jaw pain or clenching or grinding. So the medical history is so important in managing bruxism because I've been doing this for 10 years now, and over these last 10 years, I'm doing less and less dental work for my bruxism patients. So there's some bruxism patients, I don't even make a splint or take a scan or impression. I just talk to them every appointment I see them. And that's something daunting for us as dentists because we're not used to it. We love being mechanical and using our hands and cutting things up and shoving things in people's mouths. But reality is with bruxism, it's a medical condition with a neurological aspect. And a splint isn't going to fix everything. And a lot of these patients, I spend most of my time talking to. Even the ones with the splint is just the end result. Most of the time, I've done lots of talking beforehand with them, going through a history, going through self-management, referrals, etc. You would consider different investigations. So if you're especially thinking of sleep apnea or sleep disorders, that's something we can easily start looking into by doing different questionnaires. There's lots of sleep apnea questionnaires like the OSA 50, the Stop Bang questionnaire, the Epworth Sleepiness Score. If you're not sure what those are, then join my course or look up online on Google. Then we have to also, another thing with bruxism as well is it's very hard to document whether someone actually clenches or grinds their teeth. And lots of the time when you ask the patient themselves, most of them will say they don't know if they do it, or they'll say that they'll deny they do it. And then we'll see they've got jaw pain or signs or symptoms of sleep bruxism. And sometimes it will be from their partner at home or family members at home who will be a better history taker to tell you whether they're clenching or grinding or not. Sometimes there's smartphone apps which can be used to monitor bruxism, and I'll go through one that I use for my patients. And there's different instruments such as sleep studies, EMGs, EMAs, etc. And then when you're looking at the management, you have to then think, do you actually need to do treatment? So if you see they're clenching and grinding, but there's no jaw pain, no teeth wear, their patient's not complaining of anything, and there's no relevant medical or secondary issues you can see going on, you may not need to treat them. So you can just say, hey, they're clenching and grinding. We'll just keep an eye on things. There's definitely education and reassurance. So that's all the talking I normally do with patients. discussing the prognosis and expectations. So I always tell my patients, especially the ones who are really stressed about bruxism, just give that reassurance that, hey, you know, it's a normal thing. I do it, everyone does it. It's something we can never stop. Because most of these patients are stressing that they're breaking a teeth or stressing that there's something wrong with them. And it's giving that reassurance and education that it's a normal thing, you don't need to worry about it. Sometimes I leave the clinic and their clench and grind reduces significantly because they just have that reassurance and they're not stressing, which is going through that never-ending cycle of they're grinding, they're stressed, they're grinding, stress, etc. Lifestyle factors and risk stress factor education. So if they're smoking or overweight or have other lifestyle factors, I normally talk to them about those as well, or may refer them to the appropriate people to talk or do management for that. But oral appliances, that's pretty much the only thing we can do as dentists, main thing we can do as dentists for bruxism, which is why we get so tunnel vision, because we see teeth clenching, grinding. All I can do is bruxism, with bruxism is a splint. But we can also do education, teaching, talking to the patients, reassurance. And we can also look into different pharmacological approaches, such as a Botox or different medications, though I personally have never done Botox or learned how to do Botox, so I don't rely on it. And there are some medications I sometimes prescribe, but very, very rarely. I've only prescribed maybe 5 people this year some medications for bruxism, and it's not very common. So we're looking at treatment for adults. Bruxism in itself does not require treatment, as I said, and it's normally management, not treating. We can't eliminate bruxism, we can only manage and control it, only when there's problems arising. And the main function of an oral appliance or splint is to protect the dentition from damage, and it may reduce muscle activity, and we can also use mandibular advancement splints for sleep apnea management. So a common belief that we dentists have with bruxism is people who brux more will have more tooth wear. But the research actually shows there's no difference in the magnitude of tooth wear and the amount of bruxism activity observed. So lots of patients I see who clench and grind their teeth, they have no tooth wear at all. And they'll be like, oh, I'm scared of breaking my teeth. I look at their mouth like, your teeth are fine. Don't need to worry about it. But they're having other problems which are causing their bruxism, which needs treatment. So when we're looking at management of bruxism, I love referring to this article from Prof. Manfredini and Prof. Lobazu. And they say management should adhere to 3 basic principles. We have to remember that bruxism is a behavior that does not always need treatment. The indications to treat bruxism are mostly based on the presence of reported negative clinical consequences, whether it be tooth wear, jaw pain, etc. And bruxism is always a sign of one or more underlying conditions. Thus, unless the cause is identified, treatment is oriented to the management of the perpetrated consequences. So if we can't find a cause, there's no sleep apnea, no stress, whatever going on, we don't have to treat it. We don't have to treat the underlying cause, but we see wear and tear on the teeth, then I would do my crown bridge or splints or whatever. But if they have no wear and tear in their teeth and they clench and grind, we have no secondary cause, you may not need treatment. I would just have a talk to the patient, like, are you concerned about it? They might say, yeah, I am concerned that I could break my teeth. So then I might make a splint and tell them you could use it whenever you want or every night, etc. So it really involves, treatment of bruxism really involves a discussion first about what the goals of treatment are and what any underlying conditions could be associated with it, and then talking about, okay, let's do a splint or let's not do a splint. So before treating bruxism, we have to always think, is it primary or secondary? And when we manage bruxism, there's a few things that we can do as dentists. It could be self-limiting, where it could just go away by itself. We could do Botox, we could do splints, we could do different drugs, or sleep disorder breathing management. So Manfredini and Lobazu, they talk about the multiple P approach for managing bruxism. Pep talk, which is talking or counseling. Psychology, such as referring to psychologists for cognitive behavioral therapy or counseling, etc. Physiotherapy, plates or oral appliances, or pills. So in the pep talk, this is the most important part of bruxism management and is why most of my patients I don't have to treat with a splint because I talk to them for a long time. So the patients can play an active role in the self-care and management of bruxism. That's the reality of it. If they're stressed about work or something going on at home, there's only so much our splint can do if they're still stressing. And sometimes our splint may make things worse because they're now clenching on something even heavier and harder in their mouth. Now, there's this concept called Psr Physical Self-Regulation. It's a psychological technique taught from Professor Jeff Oakson from Kentucky and his psychologists. And if you want to, I'll talk a little about Psr management and how effective it is, and something I do a lot with my patients. If you want to learn more, you have to check my residency out or check out Dr. Jeff Oakson and search up Psr because it's so helpful. It would explain the concepts of bruxism and pathophysiology. So I always talk to my patients and educate them about stress management, airways, posture, which is why I work with physios, chiros, and osteos a lot. You're talking about sleep hygiene instructions. So lots of these patients, they won't be sleeping well, especially if they've got TMD or chronic pain or depression, anxiety. Most of them will have some sort of underlying sleep disorder or just very poor sleep habits. So they may be staying up till 1 a.m. every night and eating just before going to bed. They may be having caffeine or alcohol or smoking and doing activities which will disturb their sleep during the night. So if you don't know what sleep hygiene is, look up sleep hygiene on Google. You find lots of different brochures and images explaining different sleep hygiene habits, which is simple things like going to bed at the same time, waking up in the same time every morning, making sure that lights are completely dark, no electronics in the bedroom. The bedroom should only have your bed, no TVs, laptops, don't do work in the bedroom, only sleep in there, etc. So when we're looking at like psychology and behavioral education for patients with the effect they could have and what the research shows, when we educate patients on the identifying risk factors that they can take note of, the effect on bruxism is unknown because everyone is different, but educating them does make a huge improvement with quite a lot of patients. Psychological interventions such as counseling, CBT therapy, the effect is unknown, but it is helpful. Good sleep hygiene, again, unknown, but if we're getting a good night's sleep, that's going to turn off the sympathetic nervous system. Relaxation therapy, like yoga, meditation, diaphragmatic breathing, it is very helpful, especially with the patients who don't know how to breathe properly. So people who are anxious or depressed, they have a higher breathing rate than someone who's more relaxed. They'll be like that. And quite often, these patients, they'll be running out of breath when you talk to them, or they won't be able to do any dental work in their mouth properly because they're always gasping or gagging because they're always highly anxious and they're heavy chest breathers. Hypnotherapy I have found is so helpful, and I refer quite a lot of patients for hypnotherapy to manage their bruxism. Biofeedback, I don't know anyone in Australia or Melbourne which does biofeedback, but it's a psychological technique to reduce bruxism. And cognitive behavioral therapy, that's another technique that psychologists can use to help reduce bruxism. Now, with drugs are not indicated as a first step management for bruxism because of the potential side effects, and they may not be targeting the cause, but they are useful for very symptomatic cases who are perhaps, lots of jaw pain or just can't have a good night's sleep. Sometimes I may prescribe a muscle relaxant or Restovit or Valium to just give them a good night's sleep, and sometimes just having that 1 or 2 nights of sleep to break the cycle reduces their bruxism quite a bit. So different drugs that we've got out there, there's the diazepams, and with the different diazepams, which can be very effective to reduce bruxism, though there is the risk of addiction and tolerance, so that's why I don't rely on Valium or diazepams a lot. We've got Botox, which is helpful if you choose a case correctly, but it only works for about 3 months. And after Botox wears off, some people, it may break the cycle and they're all fine, but some people may not. And then they go Botox again and again for years until Botox stops working. They develop a resistance to it. So then it's like, oh, I haven't treated the cause. For me, splints and Botox are the same. They're not treating the cause, they're just managing it. It's just with a splint, they're using it all the time and it's not injecting something. With Botox, we're injecting something. They're both very effective. It just depends on how you select the cases. The tricyclic antidepressants, no effect on bruxism in terms of reducing it. Some of them can, some SSRIs can increase bruxism. So when looking in the medical histories and being in a TMD clinic, every TMD patient is depressed or anxious and they're on some sort of SSRI. So I always know this is going to be fun to treat. Botox, as I said, it's a band-aid sort of management. And it doesn't get the exact, it doesn't go for the direct cause of the bruxism. but it can help just break the cycle for a bit, give some symptomatic relief, reduce some of the pain stress which is causing the patient, and it can sometimes reduce the bruxism after it wears off. But there is controversy with it, and it can lead to adverse local and systemic side effects in rare situations, could even lead to respiratory compromise. So if you haven't screened for sleep apnea, and then you Botox someone who has sleep apnea, you could worsen their airway function. Remember, there's a protective mechanism involved. It could occasionally cause local muscle weakness. I've had some patients who said they did Botox, it didn't do anything for their pain, but now they feel they can't chew as they used to because the muscle is now weaker and their face and size of the shape master has changed, so it feels they can't chew properly. And in very rare cases, it can cause death. And this was from the American Academy of Orofacial Pain, where Jeff Oakson is a diplomat for. And I had this slide talking about bruxism, talking about Botox in rabbits, and they injected Botox in their masseter muscles. 1 month after Botox, the masseter muscles showed atrophy of the fibers and some hypertrophy of others, and also fibrosis. Then 3 months after the Botox wore off, there was still this lingering atrophy, hypertrophy, fibrosis, and empty spaces. And then if they did more Botox at this 3 months, there was even more atrophy, hypertrophy, and fibrosis. So if we're seeing patients that are just doing Botox every 3 months, we're potentially atrophying their masseter muscles or temporalis muscles over the long term, and it may never return to its normal function. That's pretty much explained that. And this is one of my slides from my, I did a grad diploma in dentistry medicine, and we were had a TMD Botox component, and they were talking about how Botox is not really the best sort of management if you can avoid it. Especially we know how to do injections. We have access to anesthetic, which is a lot more simpler and safer. So they said in this study, they compared saline placebo with a Botox injection to the masseter, and they found that there was barely any statistical difference between the placebo injection and the Botox injection. And they still say that doing dry needling or trigger point injections with LA could be more effective or just as effective and a lot safer, because just doing a needle or acupuncture or just injecting LA, which will wear off. So with splints, we all want to sort of think about, are they really effective treatment for us, especially if we've got sleep apnea going on. So before we had that question asking me about, would you do a splint, and could a splint potentially block the airway? And yes, it can. The research has shown, in this study, they looked at a sample of patients, and they found these patients, if they had sleep apnea, and then they gave them a splint, it worsened the apnea by up to 50% and increased the snoring by 40%. And in this study, their conclusion was the use of a splint is associated with the risk of aggravating the respiratory disturbances, and it may therefore be relevant for clinicians to question patients about snoring and OSA when recommending a splint. Now, this article gets a lot of crap from the dental research community because it is a very small subject of patients, only 10 patients that they looked at, and actually they've done an updated version of this paper. This was in 2004. I think around 2010 or 12, they redid this study with a larger sample, which still support the same evidence or same conclusion. But this paper gets a lot of crap from some dentists because they'll say it's a small sample, it's not representative of the research. But if you look at the conclusion, all they're telling us in the conclusion is just ask your patients if they snore or have sleep apnea. That's all they're doing. We're not saying don't do splints for anyone. They're just telling you to just ask a question, which is perfectly harmless. And if anything, it's going to help the patient because we're looking into their sleep, looking at their breathing. And I've seen so many patients who had sleep apnea, which was completely missed. They were given a splint for bruxism, and they said the minute they got their splint, their sleep got worse, their clenching and grinding, and their jaw pain got worse. So I have lots of anecdotal evidence, which isn't always scientific, but you definitely will see it in your own patients. If they've got sleep apnea and you give them a normal splint, sometimes it can make the clenching and grinding worse and make their sleep apnea worse as well. So they have shown research as well, which shows that Cpap can fix bruxism or reduce bruxism. So over here at the bottom, so during using Cpap, most of the breathing abnormalities were eliminated, and there was a complete eradication of teeth grinding events was observed. The result of this study suggests that when sleep bruxism is related to apnea and hypopneas, the successful treatment of these breathing abnormalities may eliminate bruxism during sleep. So if they're going for the secondary cause, they're going for the sleep apnea, they didn't even need a dentist. They said, no, we can just do this by using Cpap. And some patients, they can't tolerate splints. They can't tolerate a mass in their mouth. So Cpap sometimes may be the option, especially for the severe sleep apnea patients who are severely overweight. The splint may not fix everything, so they may use Cpap. And I do refer patients for Cpap in these situations where they can't tolerate a mass or the mass isn't fixing all their sleep apnea. And sure, Cpap may not be for everyone, but I have a lot of patients who love their Cpap. And they can even use Cpap with a mass or Cpap with their splint. So how do I manage bruxism? So I follow the triple P approach as well. And how I manage bruxism is I do a lot of talking at the start. So my first appointment with everyone, whether it be sleep, TMD, or bruxism consult, always goes for an hour. In that hour, I spend probably 20 minutes or so at the end talking about what's going on for them, educating them about their condition, and especially if there's bruxism going on, I start teaching them about what's going on with bruxism. That's already the pep talk, just going through my treatment plan and educating them about what bruxism, TMD, and sleep apnea is. I talk to them about this app called the Brux App, which I'll show in a minute. I teach them about awareness, because most of these patients are not aware they're doing the bruxing. And they'll be like, no, I don't do it. Then next time they come in, it's like, actually, ever since you asked me about it, I do know that I do it when I'm driving the car or when I'm at work or cooking dinner or something like that. And I talk to them about the big three, which I'll talk about more in a minute. I sometimes refer for psychologists or hypnotherapy. In Australia, there's this group called HypnoFit. They have hypnotherapists all around Australia. I use them a lot for bruxism and also for sleep disorders outside of sleep apnea, such as like insomnia, night terrors, sleep talking, sleep walking. I've had some patients where just through doing hypnotherapy, their PTSD or night terrors went away and their clench and grinding went away and they didn't need any splints. Physios, osteos, chiropractors, I definitely use them a lot because if there's a postural component or body injury component going on, they are more qualified than myself to talk about neck or back or feet issues. I could recognize and say, hey, you had back surgery or back or neck pain, etc. I think you need to see this physio or this chiro or osteo who knows how the TMJ and bruxism works, but also can look at your other parts of your body to help with that. Plates or appliances, we all know about those. And pills, very rarely I do pills, but the most common ones I would prescribe would be either diazepam or Norflex, sometimes Restovit, which they can just buy over the counter without a prescription to just help them get to sleep and break that sleep cycle. So in the pep talk, the main thing I always talk with in the pep talk is this thing called the Brux App. It was developed by Professor Manfredini. And it's an app that anyone can download on their phone, and it raises awareness and educates the patient on how to reduce the clenching and grinding and also how to become more aware of their clenching and grinding. So it retrains the habit out of their system, which is much more effective than shoving a piece of plastic in their mouth. So if you were literally my patient, what I do in every appointment, I say, get your phone out. I show them the app on my phone. I make the patient look it up. They may not download it on the day or in the chair with me because the app costs $3, and for them, $3 is a lot for some people. But I told them, hey, it's $3. It's only a cup of coffee. It's going to make a huge difference. Even though they don't download it on the day, I don't care. At least I've shown it and they've looked into it. And then I explain how the app works. I show them, I've got screenshots on my phone of how it works. And this is the main screen that they will see. The app, well, firstly, the app, it goes through a few different It goes through explaining what bruxism is. So it does that education again and reinforces what I've educated them in. And then what the app does is it sends notifications or reminders during the day to help train the patients or remind them to think about what they're doing and increase their awareness if they're clenching or grinding. So this is literally what the notification alert looks like when it buzzes on their phone. It'll ask them, is their jaw relaxed? Are they clenching their teeth? Are they contacting or jaw clenching with no teeth contact? Or are they clenching with teeth contact or grinding their teeth? Because clenching and grinding is not just the physical touching of the teeth, it's also the thrusting of the jaw, the tensing of the jaw muscles, it could just be keeping their jaw relaxed. And what I tell my patients as well is some of them, they can't get to their phone, which is understandable. I can't get to my phone when I'm working. So if they can't get to their phone, what I tell them to do is just sigh some air out of the mouth. And this is what Dr. Oakson does with his bruxism patients. He tells them, if you ever catch yourself clenching or in a stressful situation, you know yourself you're tensing or bracing your jaw, just sigh some air out of your mouth. And as you just saw, I immediately relax my shoulders at the same time because it's just our natural reflex when we sigh. We go like that. And we don't want to be mouth breathers, but it's just doing a quick sigh of relief, which will immediately separate everything, open up our jaw, separate our teeth, and relax our masseter muscles. And I tell my patients to do this, and I get them to do it on the day with me. And they normally tell me, oh, wow, I feel so relaxed. I'm like, exactly. It's so relaxing. So even if they can't get to their phone, or they don't download the app, or they can't look at their phone, if they feel it vibrating, it must be either a message or the app going off telling them what are they doing. So if they feel it vibrate and they can't check, they just go, or they can just think, it's just 5 things I have to think of. Is their jaw relaxed, clenching, contacting, clenching, or grinding? That's all they need to think about. What are they doing? And it's made a huge difference and made my bruxism treatment so much more easier because I've had some patients just from using this app, within a month, their bruxism goes away and they're like, oh, I don't need a splint. I'm like, well, good, because it wouldn't have worked for you in this situation. Now, the big three, this is something I teach all my patients as well. On the day I'm showing them the app and teaching them to do that sighing thing, the next thing we have to teach them is how to keep their jaw relaxed. Because these are patients who've been clenching all the time. They don't know what a relaxed jaw is. It's similar if I'm always having my shoulders up like this and walking around with a very tight posture. I can be taught, just relax your shoulders. I don't know what relaxed is. This is relaxed for me. Then I realize, oh, this is relaxed. So what we need to teach our patients is how to keep their jaw relaxed. If we tell our patients, I want you to focus on not clenching or grinding, chances are they will keep clenching or grinding because the brain will always do something, but it's told not to do. So I tell you not to think of elephants, you're all going to think of elephants. If I tell you not to clench and grind, you're all going to clench and grind. So I tell my patients, always think of the big three, which is having your lips closed, breathe through your nose, and the tongue on the roof of the mouth. And this is why our myofunctional therapy, breathing retraining is so important. Because what we're doing when we're doing the big three is, one, we're breathing through our nose, which relaxes the body. When we breathe through the nose, we stimulate the maxillary sinuses, and the maxillary sinuses are our largest houses of nitric oxide. Now, nitric oxide is our natural vasodilator and our natural relaxant. So most of our patients who are anxious or depressed, they won't be relaxing because they're not nasal breathing and they're not getting enough nitric oxide. If we teach them to nasal breathe, they start using their nose to start getting more nitric oxide, they feel more relaxed. That's why people who do yoga and meditation, they're doing lots of nasal breathing, they feel more relaxed. Now, when we're having the tongue on the roof of the mouth, the tongue should sit right behind on the incisive papilla. We call this the N spot. So when you say that the N, our tongue touches up there. And the reason why we want the tongue on the roof of the mouth is, well, for kids, it will help with growth and expansion. But in clenching and grinding, the tongue is a very strong muscle. And it's connected to our mandible and our throat. And we lift our tongue up, that's its resting position, and will support the mandible up and hold it up. In doing so, it will take the load off the temporalis and masseter muscles. So our clenchers and grinders, they're overworking these muscles and they're not using the tongue properly. So we teach them, use your tongue, it will start turning these muscles off, which will help reduce their pain and clenching and grinding. And I get my patients to do the big three with me in the room, and then I ask them, how does your jaw feel while you're doing the big three? Most of them will say it feels relaxed. They feel no tension. They feel no pain. There will be some who will feel some pain in their masseters. And these ones are normally ones who may have a tongue tie, or they may have very poor myofunctional habits, or they've got other dysfunctions going on, such as a neck or head issue or injury, etc. So the big three is creating that awareness, but they physically may not be able to do it because they've got other injuries or issues going on. And if they really can't do the big three, that's already telling me it's a red flag. They're going to be difficult to treat. I'm going to need, tongue tie releases, physiotherapy, etc. to help them, because no matter what I do, I could put a splint in, but they still can't relax their jaw. It's going to be so difficult to reduce their pain and clenching and grinding. And oh yeah, this is what the Brux App also shows in the phone. It actually teaches the patients to big free as well and tells them your teeth should always be apart when your mouth is closed. So when we're doing the big free, the teeth shouldn't be touching. The teeth should only touch when we're chewing or when we're eating or swallowing. During the day, they should always be apart. So Psr, Physical Self-Regulation. This is a therapy developed by Dr. Jeff Oakson and his psychologist, Professor Charles Carlson, who both work in the University of Kentucky. And basically, Psr regulation is a therapy which targets pain-related symptoms. It doesn't target the pain itself. It targets the symptoms related with pain, such as poor sleep, poor breathing, our posture, daily habits, and our diet. And it uses brief interventions and training to control these altered physiological functions, such as the breathing and sleep, etc., which is associated with the pain. So if I've got jaw pain, I'm not going to keep focusing on doing Botox or splints or anything for the jaw. I'm going to focus on training or teaching and educating patients on other physiological components which can increase pain in our body. So what we're doing with Psr therapy is we're trying to quiet down the nervous system. And this is how we're working on the central nervous system and the sympathetic fight-flight response. So by working through Psr therapy, we're quieting down the ascending information, which helps reducing pain. And it's teaching patients to activate the descending inhibition systems, which suppresses pain into the cortex. So in the clinical trial for Psr therapy, they had 44 patients with masticatory muscle pain. And they separated them into two different groups. The first group was standard dental care, or the SDC group. And this group, they only gave them a splint. They did nothing else. No education, just a splint. With group 2, they did Psr therapy, which is all education, teaching about posture, breathing, sleep, etc. And they reviewed both of these groups twice after their treatment was started. So in the 6-week review, both groups, both the splints and the Psr group, had a 50% improvement in their pain, and they also had improvements in their life interferences from pain. So we're not just talking about TMJ pain, but other chronic pain in their body. Those that had more perception of control of their body and their jaw. Those had greater mouth opening without pain. They had improvements in their distress or anxiety issues, improvements in somatization, which is related with anxiety, and improvements in sleep quality. Then at the second review at 6 months, they found that the SDC or the splint group was still the same as the 6-week review. But the Psr group at the 6 months had even more reduction in their pain and had even greater mouth opening, because they had been treated holistically. The patient was now treating themselves, and they were more aware of any bad habits they were doing. They were improving their sleep, they were improving their posture, their diet, their breathing, which was much more effective in reducing their pain and also getting them a better quality of life, compared to a patient which was just shoved a splint in the mouth and said, I'll see you in 6 months for your hygiene. So it's daunting for us as dentists to learn all this, because we're so used to just putting splints and taking teeth out and doing fillings, etc. We're not used to being a physician or a doctor where we just sit down and talk to a patient and charge them for just talking. But the reality is, that's what medical doctors do. They just talk, unless they're a surgeon or some other sort of specialty doctor. Most of the time, they just talk to their patients and they charge them for talking. So it's not wrong for us to charge our patients, to talk to them and educate them, because we're still treating them, even though we're not physically doing something to them. And that can be difficult as well for our patients to accept, because when they see dentists, they always think we have to do something physical. Why am I leaving the room with nothing being done to my mouth? All he or she did was talk to me. But the reality is, if they have an understanding what's going on, and then they leave with this feeling that they're in a better mindset of how to help themselves, it's going to make a huge difference to their overall health. So yeah, Psr gives, or just some sort of pep talk counseling, does give a lot better long-term results than just working with a splint. So I'm just going to run through a few cases of mine as well, which will help demonstrate some of the things I do in my clinic and some of the interesting cases that you see which are normally more complex. So I do see very common myalgia pain patients, but these 3 cases I'm going to show you, they're a bit more complex and different than what you would normally see. So this patient, she was a 39-year-old female who had myalgia, which is just muscle pain, and a tingling on the right-hand side of the tongue. And she'd had this masseter temporalis and lateral pterygoid pain for many years, would have it was a dull ache. She would wake up in the morning with more pains in her cheeks, and always had headaches in the occiput and behind her eyes. She also had this tingling sensation on the right-hand side of her tongue, and she'd seen neurologists and GPs, and they all said it's just trigeminal neuralgia. They tried Tegretol and drugs like that for neuralgia, which didn't work, so they just told her, you have to live with it, there's nothing we can do. She had a splint already, which she was still using every night for years. It was a upper flat plane splint, and she told me that she doesn't know why she's using it because it's not doing any benefit. She's not worried about her teeth breaking down, and she had no signs or symptoms of snoring or sleep apnea as well. So this was her dentition. Her jaw's all looking pretty fine. It's maybe could be a bit more developed, her maxilla. She's got a bill for overbite and a bill for overjet. So to me, I'm not concerned so much about the occlusion and cosmetics. I'm more thinking about the orthopedics and how her mandible is sitting inside her head. So when I see an overbite and overjet like this is enough for me to think it's compressing the TMJ too much, or compressing the condyle, the disc, and the nerves around the condyle too much. And it could only be a few millimeters, but that's really literally how small the joint space in the TMJ is. It's only a few millimeters large, and if the jaw is too forward or backwards, it can make a huge change to that condyle TMJ complex. So this was her again with her splint in the mouth, and the splint looks fine to me, like it's a flat plane splint, there's even contacts, there was no interferences. Well, actually, I don't really like this ramp at the front, but when I had a look, this incline at the front, sorry, it was discluding the bite a little bit when she protrudes. But to me, I wasn't really, I could see it was just protecting her teeth. It wasn't doing anything for her pain symptoms or her bruxism. So what I was thinking was she's got this nerve tingling with her tongue. That's a common thing you'll see with, with more complex cases who have had chronic pain for many years. If they've had pain for many years, that's when the nerves start becoming damaged and involved. And what I was thinking, she doesn't sound like a neuralgia case, because neuralgia is when they'll get intense pain. And she was getting intense pain. She was getting just this tingling sensation. And neuralgia is normally stimulated from just like light touch or air or something like that. But she was feeling this constant tingling all the time. And sometimes get worse during jaw function or in the morning when she wakes up. So these are all signs to me that, okay, it gets worse during jaw function when she's overworking her jaw muscles. It's also worse in the morning when she's been clenching and grinding her teeth. So I was thinking it may not be neuralgia, it might be neuritis. And knowing our anatomy from the trigeminal nerve, we've got the V1, V2, and V3 branch, and the lingual nerve is part of the V3 branch. So I was thinking possibly the lingual nerve is being affected from this neuritis. And how could it have been affected was the trigeminal nerve runs over here, goes through the temporalis and through the masseter and through to the tongue and lingual structures as well. And if she's clenching and grinding her teeth all the time, she's going to be overworking those muscles, and she's going to be compressing or crushing these nerves. And I can't explain why she would, or to what degree she would crush or compress them. But to me, I was telling me, okay, maybe her clenching and grinding is overworking the muscles, compressing these nerves, and causing this neuritis or tingling sensation. So I made her a splint, and with the splint I made her, it's a splint developed by Steve Olmos, but it's basically called a Psr splint. A Psr splint was something that Dr. Oakson used a lot, where it just goes in the top jaw and it has this ring, and the lab I use at normally make this bottom piece with a platform to help support it, especially if people have like crooked low incisors. If it's just a splint against the low incisors, it can be very uncomfortable. And it also helps hold the jaw more stable and prevent any super eruption. But you can make Psr splints where it's got full contact, but I like doing it with anterior deprogramming effect, because when we have an anterior deprogramming effect, effect is going to take pressure off the temporalis and the masseters. You can only tense the temporalis and masseters if the back teeth are touching. So majority of patients that I treat with splints, I'm normally using an anterior deprogrammer, but there will be some where I will be using a flat plane splint depending on their situation. And I sometimes use these as well for sleep apnea patients because it can act as a mandibular advancement splint, but she had no snoring or sleep apnea. The reason why I was using this was I wanted to hold her jaw forward, which helped decompress her mandible and also decompress the condyle, create more room in the TMJ interarticular space, and also decompress her masseters and temporalis. And basically, just within a few weeks of using this splint, her clench and grinding reduced, and her tongue tingling went away. So you can see the differences between using the splint I made her without her splint and with the old splint that she had. So you can see the main difference is I'm bringing her jaw slightly more forward. The vertical is probably roughly this, the angulation of the vertical is probably a bit different because I use a different bite from a centric bite. And you can hear her feedback. So can you just tell me what sort of symptoms you were having beforehand when I first saw you?
So I basically had a lot of tingling in the tongue and all through the jaw and along the sinus line there. And since wearing the dental splint, I think this is the 6th week now, around the 3rd week, I had a reduction in the whole tingling in the tongue, which was really good because it's really off-putting with that tingling. The mouth guard has definitely helped.
Great. And you used to be getting headaches as well?
Yeah, I used to get quite a fair few headaches nearly every day, and since wearing the mouth guard splint, I've only had one major headache, so it's been a big improvement.
Great, that's beautiful. And you're just using the mouth guard at night?
Yeah, mouth guard at night, top
Awesome.
and bottom.
Great.
Yeah.
Beautiful. Thanks a lot for that.
No worries.
So the reality with this patient as well is I didn't just use the splint for her. Before I made the splint, I also got her to see my physios because when she had the headaches behind the eyes and the forehead, that's a common trigger point headache referring from the neck and shoulders. So she told me in her history she had lots of neck and shoulder tension, and when I palpated them, they were very sore as well. So part of her treatment as well was getting to see the physios first before I made the splint, because that's going to help turn off some of the neurology and release some of the muscles, which will also help reduce her clenching and grinding and make it much more easy and tolerable for her to use a splint, because she was a bit afraid that she wouldn't be able to handle this splint because it's on the top and the bottom and it's got this ring at the front. So I told her, well, if it doesn't work, at least we've given it a try and we may try a different splint. And the fact that the physios were able to help reduce some of her pain from the start, but not all of it. And that's when we said, okay, now we've got the physios working with us. We'll now use the splints. And the physios were also talking and teaching her about posture, breathing, looking at other injuries in her body, etc., which was all complementing everything that I was already doing. So with this next case, this is a patient that I only just saw for the first time about 3 or 4 weeks ago. And I'm still treating her because she's a very unique, complex case. So she's got dystonia and nervous tics, which is just like twitching of the face. And she's a 54-year-old female, and in 2018, she slipped and fell in IKEA and fractured her scaphoid, which is in the wrist, which is completely unrelated to here. But 3 weeks later, after that injury, she noticed her jaw was pulling off to one side, and she started getting pain and headaches, which was weird because her injury was down here. Then in May of 2018, she had surgery which was a non-union of her fracture and bone graft of a ganglion cyst, which had developed in her wrist. Then she went traveling overseas for 12 months, and whilst in London, she noticed her jaw was moving even more over to the left, and she was losing more control of her jaw muscles. Then she started noticing she was having difficulty talking and stuttering and having changes in her temperature as well. She was getting more hot and flushed easily. And then she was diagnosed with chronic regional pain syndrome a week later. And now, ever since that day in 2018, she's been getting dull, achy pain, which gets worse during the day. And it's pain not just in her face, but also in her whole body. And ever since then, she's never been able to talk normally for all these years. And she's currently under care of her GP, a neurologist, and also an osteopath and a physio that I work with. So basically, dystonia is characterized by painful, prolonged muscle contractions that result in abnormal movements and postures. And in particular, for this patient, she had lots of oromandibular dystonia and difficulty talking. And the reason she had difficulty talking was her lateral pterygoid, masseter, and her tongue were always spasming, and she couldn't control them. So she couldn't make intonations or verbalize her words properly. Even though she was cognitive and knew what she wanted to say, she physically couldn't do it because her muscles just wouldn't obey her properly. So this is her. She was very, very excited for me to show off her case because she literally said, if I wanted her to come in here in person, she would come in here in person. I was like, no, you don't need to. But she was very happy to show off her case because she's such a positive person. She's so she just wants anyone who can get help with this sort of situation. If anyone can be educated, she wants to be able to be a good teaching model, as she said. But as you can see with her tics, most of her tics were always on the right-hand side, not just in her face, but also down her right shoulder and her leg. And as you can see from her smiling, she couldn't smile properly. Her mouth, it's not the best. Oh yeah, she also was diagnosed with sleep apnea, but that was less of concerns at the moment. Deep palate, etc. And this is her talking with nothing in her mouth.
Okay, can you just say the quick brown fox?
Quick brown fox jumped over the lazy dog.
And now can you put the pressure and repeat that again?
The quick brown fox jumped over the lazy dog.
Beautiful.
Okay, so what she was doing there, she told me that she's been looking for a dentist who can help realign her jaw properly to help with her dystonia and ticking. Because she knew since 2018, if she pushed her jaw in a certain direction and her bite was a certain position, her dystonia would stop because she said herself that she could feel her nerves were relaxing and her jaw was relaxing. And she's seen many dentists and orthodontists who said, no, that's all bullcrap, it won't work, I'm not going to do anything. So all these years, she's been trying to find someone who can help her. And what we did was I took a bite registration to make a temporary splint for her. And working with her, we sort of figured out the best position and opening to hold her bite, which was roughly where she was pushing her jaw before. And I just got her to bite on different tongue blades to sort of hold the bite in the position we wanted. And initially we started with, she felt it needs to be open quite high, so we started with 5 tongue blades, and then we took it down to 3 tongue blades, and 2, then she found 3 was the vertical in her, using 3 tongue blades was best, and then I had to use this in her mouth, and within seconds, she had a huge improvement. So you'll be able to see, this is on the same day, just giving her a bite registration.
Good. So can you just tell me how things are feeling now with this one?
Jaw feels stable.
Yeah.
Not tongue isn't protruding out like in the last one.
Okay. And how's everything feeling? Feeling good about everything?
Neck and back tighter, but the front feels more normal.
Yeah, that's good. And you definitely sound like you're speaking.
Speech, still hearing the intonation wrong.
Yeah.
But this is so much easier. Tongue is back further, but not rigid.
So you don't feel that spasming or tension in it?
Not the real hard spasms.
Okay. Can you just say the quick brown fox again?
The quick brown fox jumped over the lazy dog.
Beautiful.
So you can see just within a few seconds of having her jaw in a more decompressed position, taking pressure off the muscles and the nerves, she was talking a lot easier. And what I did was I got her to take that bite registration home and test it out for a week. And I saw her a week later to just see how things were going. So this was at the 1-week review.
So
the quick brown fox jumped over the lazy dog.
Awesome.
So much better than it was.
That's good.
Not quite right, but we're getting closer to controlled.
Yeah.
controlled speech.
Yeah, and how have you...
Intonations and inflections and emotion and that, I can actually speak again fairly normally.
Yeah, that's great. And you're feeling that the tongue is a bit more relaxed with just the right side in, correct?
Certain positions, like this, it's sort of, it's a constant flickering. It's all over. Nowhere near as bad as it was. With the other one in, it's still, I feel like a snake, hang on.
Yep.
It's constantly poking in and out. The jaws are not quite in the right position.
Yeah, okay. Yeah. All right, that's good.
So you can see just from having proper nerve supply to her muscles for a week was already making huge changes in her ability to speak and control her muscles. And I'm seeing her again later this month. We've just been trying a few different bite positions to see what sort of bite feels most comfortable for her. And she's been taking a diary and updating me. And then we're going to see what sort of splint we may make to sort of decompress her jaw and hold in a stable position. Now, she's a very unique case, obviously, and very complex. I'm also working with a neurologist and her physio and osteopath through this. And the reality is she might need to use a splint every day for the rest of her life, even day and night time, to get her proper jaw function and speaking. But reality is she doesn't mind it, because if it's getting her normality in terms of speech and her function, it's going to affect her everyday life again and get her back some normalcy, which she hasn't experienced for the last 4 or 5 years. So this last case, I posted this on my Facebook last week, or a few weeks ago actually. This one is a female who was having some locking of her jaw back to start, but hadn't started completely just yet. So this was someone who could start developing a lock or dislocated jaw. So she was a 40-year-old female, and she presented with left side clunking of her TMJ and difficulty eating, and she had no pains or headaches. So this was the asymptomatic clencher or grinder, but she could start feeling her jaw wasn't sitting the way it used to. Now, her maximum jaw opening was about 38 millimeters, when normally we want it around 42 to 52 millimeters. Whenever she opens her mouth, her jaw deviates to the left-hand side, so it swings off to the side and back to the center. And she started noticing this left side clicking was something that only just started about 12 months ago. When I hold her jaw or had her bite in a certain position, her jaw clicking went away. She had no snore and sleep apnea, so we covered any secondary causes from that. And she noticed she clenches a lot during the day and been feeling this tightness in her left TMJ and temporalis for the last few months. And she's been finding it more difficult to open wider gradually as well. So the main question we have to ask is, when should we be treating clicking in our patients? And we shouldn't be treating clicking, we should be treating for symptoms. So if we see symptoms of pain or locking or things that weren't happening previously, that's when I'd be thinking, maybe we should start doing something before it gets worse. So with the TMJ, going back to anatomy, we've got the condyle and the disc on top of it. And then we've got the lateral pterygoid. The superior body is attached to the disc, and the inferior body is attached to the condyle. And when we open and close our mouth, normally the disc should stay on top of the condyle, but in the clicking case, the disc is slipping off and then slips back on or off. The disc normally slips forward because the lateral pterygoid can pull it forward, but it can also sometimes go to the medially or laterally, very rarely posteriorly. And locking is when the disc is completely slipped off and doesn't slip back on, sometimes because the lateral pterygoid is too tight or the ligaments have been too stretched or torn or elongated. So this is our patient. When we had a look at her, I always look at the posture and the bites of our patients. So we can really see she's got a huge cant going off to her left-hand side. She's got this lean in her posture going off to the left. You can see how her neck doesn't look completely straight as well. So whenever I'm seeing a locked jaw sort of case, I'm always thinking about the surrounding musculature which is going on. Because when we clench and grind, we don't just use the temporalis master, the lateral pterygoids. We also do use the SCM, the sternocleidomastoid, and the supra and infrahyoid muscles. if we're using the suprahyoid and SCM muscles, we also do tense up the occipital, the trapezius and shoulder muscles as well. So lots of these patients who have a TMJ issue or clenching and grinding, they'll also have occipital headaches or cervicogenic headaches because their posture is crap and they're leaning forward or they're off-center, etc. So this is her bite, and part of the reason why her posture is also off-center is she's got a pretty average bite, or bad bite actually. But you can see how her maxillary suture, it's a bit skewed, off-center, which to me, this is where like cranial osteopathy and cranial osteopaths can really help, especially if she was a kid, because her suture is completely off, which will make distort her maxilla, and also then distort her mandible to want to shift and move around as well to an unnatural position. And she's also got this missing tooth on the left-hand side, which would mean she will have to bite differently because she's got lack of support on the left. Now, I know before I said occlusion plays a very little role in clenching and grinding, and it does. But when we're looking at biomechanics, how the TMJ works with a locking jaw or clicking or locked disc, that's where the occlusion biomechanics start becoming important, because we have to, I'm always trying to think, are the forces in her mouth balanced? Is she able to bite on the left side as evenly as the right? Is she chewing more on the right or chewing more on the left? How does her neck and her muscles in the head and neck hold and support her jaw if her jaw is off-center or at a cant or angle? So what I'm also thinking of here is what has caused this joint locking or the gradual increase in jaw locking over the last few months. She's had this malocclusion her whole life. She's had this bad posture probably for her whole life. Why is it only the last 12 months that things have gone worse? Well, that's where the bruxism, when I investigate further with her clenching and grinding, she had told me that she had been going through a bit more stress lately. It was COVID, so everyone was. She was clenching and grinding a lot more than she used to. So to me, it was telling me she was overloading her jaw too much. Probably every night she was putting more pressure and overworking the disc and tearing or stretching the ligaments in the disc, which would make it more difficult for it to heal, and then also make it easier for the discs to get locked and stuck. So everyone has a certain degree of adaptability, and this is a concept of Dr. Oakson teaches a lot about, which explains why some people will have TMD and some won't have TMD. Because we all have these different etiological factors that can cause TMD over time. We could have occlusion issues. We could have trauma, not just trauma to the face, but physical or emotional trauma. We could have emotional stress. We could have deep pain inputs, such as referred pain, or we could have parafunction from clenching and grinding. And all these etiological factors can cause TMD. And then it's our adaptability of the person, whether it be their genetics or their biology or their hormones or how well they sleep at night, how well they breathe, what's their diet like. All this adaptability will then determine whether the patient will have TMD or whether all these etiological factors will just let them be normal and get through their everyday life. So before we started treatment for her, actually, I didn't just shove a splint in her mouth. We spoke to her a lot about what was going on, which was causing her clenching and grinding. I got to see the physios to help work on her posture and her neck. And then we started working with putting a splint in her mouth, because she had no wear or tear on her teeth, so I wasn't worried about her teeth breaking anytime soon. The physios would already start working on her jaw to help unlock it or mobilize a bit better. And then with the splint I made for her, I made her splint go on the bottom jaw and it's bring her bottom jaw a bit forward. The reason why I brought her jaw a bit forward was her clicking went away and she could open wider when her jaw was a bit more forward. There is very minimal risk of bite changes when we use a splint like this, but reality is she's not using this for the rest of her life. So since she's only using it for a couple of months, there's barely any risk that she's going to get a bite change, especially if it's going to restore her function, prevent her jaw from locking, and prevent any further pain from coming on. So you can see in these videos, this is her jaw opening initially.
Wide as you can, and close.
See the big deviation?
And open again, and close. Perfect.
And this is her 3 months after she
Okay.
was using her splint.
Close. Open again. Close.
You can see there's no more deviation.
One more time, open. And close. Beautiful.
And the jaw still it angles a little bit off to the left, but it's because there's always going to be some damage there because she's really torn or elongated or stretched the ligaments holding discs together. And ligaments will never go back to their normal size. So there's always going to be a very mild deviation, but it's not as bad as it used to be. She has no more clicking or feeling of locking, and she can also open a lot wider now, and she's eating normally without any pain or without any difficulty opening or chewing anymore. So thank you all for your time. If you do want to learn more from me, feel free to join my Facebook group or reach out to me if you have any questions. People email me cases all the time. And if you have any questions now, feel free to ask. Yes, at the back.
Damian, I have patients that clench while working out.
Exercise, yeah. That is very common, and that happens with everyone, even myself. So because we're, especially if it's weights, that's the time most people will do clenching. Any sort of exercise, we activate the fight-flight response, the sympathetic nervous system. So that's gonna make us clench and grind. And some may do it more than others, especially if you're doing more strenuous activities or doing big deadlifts. So I have some patients where I make them a splint to use when they're doing their exercise, or if they're doing football or contact sport. The mouth guard won't just be a shove in your mouth guard. I'll make the mouth guard in a certain bite position, so it will help decompress the jaw or help prevent or reduce their forces from clenching and grinding. So clenching and grinding during sports is very common, and it's sometimes it's unavoidable, especially depending on the sport they do. So the management would really depend on the concerns of the patient, if they're concerned of breaking the teeth or they're getting pain while they're doing the exercise. And most of the time they won't, because if they're doing sports, most of the time they're taking good care of themselves and they have good diet, good habits, good exercise, etc. So yeah, did that answer your question?
Yeah, I was asking about the type of splint. So hard splint or not hard splint?
Everyone will be different. It depends on the sport. But yeah, if it's like a contact sport like football, then just your normal mouth guard, whatever mouth. Are you concerned about the splint breaking while they're... yeah. I normally use hard splints. Yeah, I haven't made a soft splint in ever, really. Like, I can't remember the last time I made a soft splint. Yeah, but yeah, I normally use hard. It's really depending on the bite position in these situations, if they're getting pain. Because if the bite position is off, it can also affect their posture. And if they're doing big, heavy weights, their posture is really important because it's going to affect their core and their structural control, which is why most of them doing weights clench a lot, because when they're clenching, they're stabilizing their structure at the same time. So yeah, normally I would want to do very minimal vertical opening, because we're mostly doing it just to protect their teeth, if anything, but also trying not to alter their structure and posture too much.
There's a Maxvac surgeon in Sydney, Rob Mitchell. He trains the under-18 Olympic weightlifting team. And he's shown by increasing vertical on their mouth guard, they increase the amount that they can bench press. But he uses that for all of them to stop cracked cusp syndrome, basically. Yeah. They're the same guys that, you know, like this, they're drinking protein shakes 24/7. Any tips, Nick?
There you go, you just said it all. Just protein drinks, no.
But he uses like laminate mouth guards, but he increases the vertical using, have you heard of applied kinesiology? No? Like I've got a deep bite, right? If I clench really hard, yeah, it's easy to push my hand down, even though I resist it, okay?
Yeah, I normally use the phonetic bite, which pretty much is counting, going 65, 66, 67. When we say, or Mississippi, S sounds just naturally brings the jaw down and forward, which helps decompress the condyle and mandible. And yeah, that's why I work with chiropractors, that you can do applied kinesiology to test the bite and see, oh yeah, this is a good bite and vertical, to put the splint or mouth guard in.
Would it be right, you've got two different... You'll have a day and a night sort of positioning?
Not all the time. At the start, when I first started all this 10 years ago, I learned from Steve Olmos, and he's very into doing day splints and night splints for most of his patients. I don't know now because I did this course 10 years ago. But these days, I started with that, day and night for everyone. And then over the years, I've been doing less and less splints. So most of my patients, I have to say 90% are just night only. The remaining 5% will be day and night. Remaining 5% will be no splints. Yeah.
Any other questions, Dr. Teo? Yeah.
I think you mentioned, was it hypotherapy that you refer a lot
Oh,
for?
hypnotherapy, yeah.
Hypnotherapy, sorry.
Yeah.
Oh, what does that do, or what is that exactly?
I'm not sure. So you'll have to talk to a hypnotherapist about that, but, because I've never been to or met a hypnotherapist, but it's just like hypnosis. Train people to reduce any stresses going on in their life. So from the feedback I've heard from my patients, like there was one who had PTSD and night terrors, and she had sleep apnea. Her sleep apnea splint was helping her breathe better, but she was still having very poor sleep because she was screaming every night because of her PTSD. So I sent her to the hypnotherapist. They did their magic, and ever since that 2 sessions, she had no more PTSD. She was sleeping better. She's still seeing them. I know one of my friends saw a hypnotherapist for smoking, and he told me in his sessions for smoking that you have to be open to being hypnotized, or not being hypnotized, but open to the concept of wanting to fix yourself or fix the problem. So hypnotherapy, I don't give it to all my patients because I first ask, you have to talk to them and see if they're a good candidate, if they're willing to fix themselves, or if they're in this position where their mind is open to be wanting to help themselves. And that's where hypnotherapy works. And I used to observe a dentist who did hypnotherapy for his dentistry to help calm and relax his patients, help with gagging and things like that. So I don't know how it works, but it is effective depending on the situation.
Any other questions?
Oh, at the front here. Yeah,
Thank you.
that's all right.
So if a parent came in and brought their child, for example, 5 years old,
Yep.
and said that they can hear them grinding most nights of the week, what would be your protocol for how you examine them and whether you decide to send them to an ENT?
Yep, sure. So sometimes I would ask if the parents haven't physically seen what the child is doing at night, but they're only just hearing it from the other room, I'll tell them to go in the room at night. Don't watch all night, but they could just pop in every now and then, see what the child's doing, if they're snoring or choking or gasping, refluxing, etc., or tossing and turning, things like that. Some parents may record it with their phone because they're that obsessive about it, which is good, it helps. But if I'm seeing the child in the chair, well, firstly, I'd be looking at how much wear and tear is going on. I'd be looking at the dentition. So let's say it's a 5-year-old to be primary dentition. I'd be seeing if there's primate spaces, whether it's underbite, overbite, crossbite, etc. So I see malocclusions. I'm thinking airway issues, or if not airway, at least growth, myofunctional issues. Looking for tongue tie, looking for tonsils. You can't see adenoids, but I can look for the tonsils, get them stick their tongue out. How Derek actually looks for adenoids is he'll get them to say banana because they'll have that nasally sound if the adenoids are blocking their nose. So they say banana like that instead of banana. Or more nasal, so maybe the adenoids could be blocking. Our lateral cephs can sometimes catch the adenoids or see large adenoids, or CBCTs definitely will see large tonsils or adenoids. Patient history, so don't ask the kid. Or sometimes you ask the kid because sometimes they will tell you some useful information. But you ask the parents, does he wet the bed? Does he how's he doing at school? Is he hyperactive? Does he have ADHD? Some of these kids may have ADHD and be on Ritalin and stuff like that already, which will increase clenching and grinding as well. So lots of history taking and just look at these different airway and occlusion signs and symptoms. Then depending on what I see, I'll then sort of think, will I maybe refer for some investigations such as OPG or Ceph or CBCT, maybe not for a 5-year-old, but OPG or Ceph could still give us enough imaging. Or I might just say, let's go straight to ENT, even though I may not see tonsil adenoids. I'll just be thinking there may be something in the nose or the adenoids, which I can't see. Or also ask my ear issues, because lots of kids, they'll have, if they've got ear issues. They'll have ear infections or history of grommets or lots of ear pain, things like that. Jaw pain, clicking, palpation of the jaw, assessing of that, yeah. So just from the history taking and what you see, that would determine whether I would refer for different records or refer to an ENT or maybe a pediatric sleep physician or maybe an orthodontist like Derek. Yeah. All right. Any other questions? Yeah.
You mentioned about taking OPG or LETSEF. What would you assess when you're taking those?
Sure. Well, one, the orthodontic stuff that we know, class 1, class 2, crowding, impactions, etc., caries and all that. Sinus OPGs, you can look at the sinuses, see if they're looking occluded or not. You can sometimes see the deviation in the septum, so you may want to do a frontal PA as well, because then you can see the deviation and cants in the bite. You can look at the condyles as well. To me, where the condyles are worn down isn't always important to me because everyone's condyles are going to have some degree of wear and tear. But for kids, it's not that important. But sometimes it can be idiopathic condyle resorption, where the condyle just resorbs for no reason at all. So you can sometimes pick that up on an OPG or CEF. CEF, you would look at the size and shape of the airway. And I know I said before that some of the literature, they say it's not as representative as someone sleeping supine, but hey, it's still better than nothing. And you could also see tonsils or adenoids on the CEF sometimes as well. And just the position of the bite. If you may think, oh, it's a class 1 bite, but when you look at the CEF, like, oh shit, it's a class 2 bite. Yeah. Oh, last one, yep, sneak in one more.
So would you consider orthodontic treatment for those 2 patients who had
Those adults?
Yeah,
No.
those shifts and all that?
No, for adults especially, most of the time they don't want adults. They don't want ortho, sorry. So only if they were really wanting orthodontics, or I saw orthodontics could make a huge change, improvement for the functional issues for the jaw. But like these patients, I normally tell them for adults that you might need orthodontics, and especially if the splint doesn't work or it's only working partially or they can't stop using the splint and they want a more permanent solution without having to use a splint, that's when I then have the discussion of, okay, we need orthodontics. That's where Derek would come in, or I also work with my max-fax surgeon, Roland Barrowman, who works with Derek as well. So yes, they would benefit from orthodontics, but again, it's also a discussion if they want to. And I'd normally have assessed that from the start of how interested they are in orthodontics, whether something they want to do, etc. Yeah.
On that point, if I can say something,
Yeah.
There's nothing in the literature to say that an improved occlusion is going to help the joint. Do you see? So sometimes I get referrals where I ask the patient, why are you here? And they say, well, I've got a clicking jaw and my dentist said it's my bite is out, and if I straighten my teeth, it'll fix that. There's no way, and that's one of the big misnomers. And if I can just add 2 things about bruxism in children, right? If you look at the evidence-based research, there's the 5 biggies, tonsils and adenoids. And so, yeah, you ask the questions associated with sleep and snoring, et cetera, et cetera. The other big one is silent reflux, or GERD, which you can only really pick up with a very special study, which is not pleasant for the kid, but you can ask questions and you can look at erosion in their mouth, etc. Right? Then there's a condition called restless leg syndrome, which you can only really pick up from a sleep study. And then the treatment of that is normally high doses of iron supplements. So can you see how it's not just one cause, one thing, but they're the 3 big ones. Now you add to that idiopathic. There is some research to show that people brux during their mixed dentition in the change of dentition, and they just stop of their own. And there's also some research to support parasites in the gut causing bruxism. So can you see, I don't think you can just say, if a kid bruxes, away you go. But when I went to dental school, we were taught stupid things like, if a 5-year-old's bruxing, they're highly stressed. I mean, I don't think so, right?
Yeah.
But I do get the parent who'll say, when I'm treating their teenager, we went camping the other day. It's the first time I've slept next to my 5-year-old, because normally he's in the bed, and we couldn't get to bed because the kid's just grinding all the time. So you've got to ask the other questions associated with that. Yeah. Thanks.
Thank you, Derek. Yeah.
Well, great lecture. Thank you very much. Good.
Oh, I've got. Thank you.
So, another question?
Yeah. One more.
The very last question.
If you have a question, you can ask me after. I'll stick around for a bit, or email me or anything as well.
Just a quick question. You were saying that you don't really use flat occlusal plane splints. Why is that?
Well, most of the time, the patient has already come with me with a flat plane splint and it hasn't worked. One reason why is they wear down so quickly because contacting the molars are always going to break it. So you will have to keep adjusting for the rest of your patient's life or the rest of the splint's life. Two, it still is, as I said with anterior D programs, it turns the masseters or temporalis off more compared to a flat plane where it's still touching the back teeth. There are some situations where I will use a flat plane because it can help with myalgia pains better in certain situations. It's difficult to explain that in this situation and here, but and the other reason why I don't use flat plane splints is it just mostly just involves me doing more work and adjusting. But I do know there's a great dentist in Cairns, Dr. Bob Gibbons. He's been doing TMD and Bruxism for 40 years. He uses Michigan flat planes for all his TMD cases, and he gets amazing results. But he tells me he has to do so much grinding and adjusting, and I'm like, and he knows how to do it. With me, I don't have the patience to do that grinding and adjusting. But for the patient I do it really does help them. It's normally really effective for myalgia with no big joint issues, joint locking or issues like clicking issues. So it's normally very effective for myalgia. It's just compared to an anterior D program, you just need to do a bit more adjusting because they're going to break it or wear it down in a few months. Yeah. Yeah, no. People just like hearing my voice. You know. I do. Yes, go on.
I was just wondering if you could tell us if there's any benefit to using NTIs.
Yeah. Yes, they are an anterior deprogrammer, but only use them temporarily because since they're partial coverage, they will cause bite changes. I've seen one patient where it was funny. I had two NTI patients on the same day. They've both been using it for years. One had huge anterior open bite, one had no bite changes. And that's the thing, it's unpredictable. We all have this research saying that a mass or splints can, anterior repositioning splints can cause bite changes, though I've seen patients who do get bite changes, people who don't get bite changes for using the same splint years on end. So NTIs, they're designed to be a temporary appliance, and they're amazing because it can be a huge diagnostic splint to just say, hey, you know, it's working. Now let's transition you to a proper full arch coverage appliance so there's less chance of tooth movement. So that's something, because we don't get taught, I didn't get taught about NTIs. With most people who use NTIs, just saw in the brochure or their principal dentist has been using for years, but there was no instructions of, just use it temporarily. Like I don't think in the book, I can't remember what NTI instruction book says, but I don't think it says just use it temporarily. It just tells you how to fabricate it and make it, but it doesn't tell you use it temporarily because it can cause bite changes. But they are great appliances, yeah.
Thanks.
2-3 weeks is enough because if they're not getting any improvements within 2 or 3 weeks, then either the bite is wrong or it's not the position for their jaw. Yeah.
Anyone else?
Okay, well, thanks very much for coming. Thank you for a great lecture.
Thank you, Derek.
So one a month. Next one's a bit earlier than planned, just because of things that were going on. So 2nd of April. And if anyone wants to know about lip and tongue ties and when they're indicated, how to do them, that is the lady. And Donnie here, of course, who looks after all my little tethered oral tissue patients, and they love that.
Mine too. I send lots of people to Donnie.
Great. So look, there's plenty of food, plenty of wine for those who want to hang around and ask some more questions, maybe.
Yeah,
right?
I'll be sticking around for a bit, so feel free to ask me any questions.